Now, data, I think, is that one word that we've all heard a lot about today. And I think that, I mean, there's a term that says data is the new oil. And that's exactly where we stand today when we talk about healthcare as well. I think everybody in this room owns a smartphone. Maybe about 20%, 30% may even have wearables, watches. So there's constant data collection happening. And I think we are more aware about our health now than we ever were because of all these gadgets that help us with data collection. But have you ever wondered what happens to that data? What can be done with that data? And is that data secure? What all can be extrapolated from that data for future healthcare treatments? For that, I have this very esteemed panel with me, starting with Dr. Arjun Dang from Dang's Labs, Pooja Chatrath from Oncquest Labs, and Mr. Harpreet Singh, Dr. Harpreet Singh, who's a scientist with the Indian Council for Medical Research, ICMR, and Praveen Bist, who's the CIO for Amrita Hospitals. Now, all of the people you see on this panel are working with a lot of gigabytes of data under different circumstances. So I'll start with Dr. Dang. You have a lot of patient data available with you. How do you see this data being used by you? I mean, since you collect different forms of data, to prioritize patient outcomes on the health front?
So thanks, Roshun, for that question, and extremely pertinent and relevant also to kick off this session. And so the data that we are collecting from patients can obviously be used in multiple things to impact patient outcomes. And starting right from making a diagnosis, where you get the genetic, environmental, medical history of the patient, the past records, not only through predictive analysis, where you can see the trend of a particular parameter and then predict if there is a disease that's brewing in the human body, but also to come to a particular diagnosis. There are different departments with different values that all need to be correlated in order to come to a comprehensive diagnosis. Now, even when we talk about complex cases that need multidisciplinary doctors or multidisciplinary teams to actually cure a particular disease, again, all that data is extremely crucial, not only to be compiled in a standardized manner, but good quality data that is based on scientific evidence to direct the team of doctors as well. So apart from personalized medicine, also known as precision medicine in the treatment aspect, also a lot of data that we collect, even through serosurveillance studies, even the data that we collect from conducting various clinical trials for drugs, for vaccine development, etc., can help even help the government to guide policies. Like even in COVID, all of us saw that the genomic surveillance, where we were tracking the variant of the COVID virus, helps the government understand how to make the policies. Also, if there's a particular vaccine that needs to be added to the national immunization protocol, etc. So the data that we have needs to be understood, compiled. It should be standardized so that it can be compiled and then leveraged for better patient impact.
Okay, since you spoke about standardization of data, I think I'm going to toss this to Dr. Harpreet Singh here, because he works with the ICMR and they've done a lot of studies on different forms of data, especially with COVID also. What kind of data standardization do we have right now? Or if not, is there a call for better standardization?
Yeah, thank you. Thank you, Roshun, and thank you, Financial Express, for inviting me here in this forum. So I'm Dr. Harpreet, and I'm working in the ICMR as a scientist. So my team, but the question that you've asked about standardization, we have been working on this standardization since last 5-6 years. So now I can say, at the government level as well as at the research level, there is quite substantial progress has been made. And we are, I would say, very close to achieving the standards. The standards not in terms of looking at application, having some selected set number of fields. That is not the standard. Standards are when your systems can communicate with each other. So that is what the standards are. So I would just take 2 minutes of yours and to give you more light on this. So my team, as I said, is working with various programs of ICMR as well as of the ministries on developing data systems for those programs. So when you look at digital health, there are essentially two very distinct components of digital health. Most of us are talking about digital health in terms of services, care, and delivery. But then there is another component, that is research component. So digital health research data. So the ecosystem, if you're talking data, digital health ecosystem, it has two components, and the digital health research data ecosystem is also equally important. The first component, services, care, and delivery, is more or less standardized. I would say if you have EHR and then other systems in place in hospitals, the data is more or less standardized. But if you talk of this research, it's a jungle out there. Till now, it's a jungle out there because we fund a lot of projects. All of these projects involves data collection, and the data collection in research projects, it is very important, but it is collected in a diverse, there are a lot of diversity in data collected in research projects. So there is lot of requirement of I would say, governance, policy, legal framework, innovation. So a lot of requirements are there because we need that. The other component, the research component, is also very important. We have to standardize that component. So what I would just give you, three areas which requires very strong intervention. One is governance, policy, and legal framework if we want to introduce standardization in the research sector. NHA is doing a lot of work. This recent policy on health research data management talks a lot about anonymization, data ownership. Excellent work it has done. But the thing that is required to be added in that is more focus on the data standardization, particularly in the form of data planning, data collection. So probably it may not be the role of entirely of NHA. Other agencies like ICMR, DBT, DST, they have also to come up and put up policies. Then we also require innovation and development of tools and technologies in digital health. So I heard, there are a lot of talks about AI ML based tools which can do a lot of predictive. But these AI ML tools, they require data for development, and from where this data will come. So right now, what I have seen with lot of development of these tools, these tool developers, they collaborate with one hospital, collect data, develop tool, and then try to implement. This is actually not the way. We have to have some national gold standard data sets so that any developer, any institution, whosoever wants to develop AI ML tool can use the data with the proper versioning and can come up with the results so that comparative development of tools by different agencies can be done first thing. Second, if somebody comes with a novel tool or a new tool from outside, there should be a technology evaluation of that tool, efficacy of that tool using those gold standard data sets. We are already working with Indian Institute of Science on this, and we are trying to create those gold standard data sets. And in fact, I would say that NHA and Niti Aayog, they are also working on similar lines. NHA is coming up with a digital platform where all this data will be collected. And Niti Aayog is also working with this image bank, cancer image bank particularly. So there is a work which is going on. Third area, which is very important, is strengthening the communication between system to system, which is right now is not very much looked after. So we also need some, what you call a robust and flexible framework or a platform where system to system communication can be strengthened. Dr. Dang's lab has a system, and Dr. Lal's network also has a system. So how about communication between these two different systems? Say Amrita Hospital has one system and AIIMS has another system, but communication between these systems is right now very limited. So we need to put up those kind of flexible, robust frameworks or platforms which can help. So these are just big examples I have given. What about the researchers? A lot of researchers are collecting data on diabetes, tuberculosis. the communication between data collected by one researcher on diabetes, thousands of patients. We have a lot of networks which are collecting data on diabetes, tuberculosis. This communication is also needs to be strengthened. So these are 3 areas I think we should focus on. And I'm putting these 3 thoughts on the table.
Right.
Let's discuss.
No, very interesting that you mentioned about standardization and the need for one source, to be able to link all this together. How about, maybe I can take this question to Praveen. We're talking about the ABHA now, the Ayushman Bharat health account, which will be a single number. And we already have our Aadhaar number now used for many government records, including it'll probably soon make PAN numbers redundant and even driving licenses redundant. So do you think that this one single number could probably be the unifying factor? I'm not talking about the software part, which still requires a lot of interlinking, but at least as a patient record?
Yeah, thank you, Roshun, for putting this question. And again, there is no good answer to this. I would say yes and no. For example, United States, all of us know that they have something called Social Security number, which is very equivalent to Aadhaar, not the Aadhaar, but the ABHA number that we are talking about. But unfortunately, that is not mandated in any of the hospitals in the US. Patients have their own privacy requirement, and they are allowed to share or to keep it confidential. So the question goes back to if you put everything all in one basket in a way. So it has its own advantages wherein you can link the data. You can very quickly from one identifier go to the next identifier and get their respective data. But then it has its own challenges also. So I think in that context, it's very, very critical that we look from the complete spectrum of it. And also, as we are aware, India is a much more diversified country compared to some of the Western countries. So we have to keep that perspective also in play. So with that said, I think it's a good initiative when it comes to standardization, but we can't necessarily enforce it as a single identifier alone to be used for every single transaction. So there are advantages of it, but we just have to be careful because policies that we implement along with that also will play a very important part to it. So, there is no good answer to it, unfortunately. So there are advantages, but at the same time, we have to be very, very cautious about it.
Right. And I think the other issue with so much of data being collected and available, and since you deal on the technology side, I'm taking this question to you now, ma'am. Data security, especially with the amount of patient data that's available, and privacy as well. I mean, I probably wouldn't want my insurance company to know that I have hypertension or diabetes or something like that beforehand when I'm buying a policy, because otherwise my premium will go up. So what kind of, and then there's also the fear of, the insurance company being sold this data from the healthcare provider. So what kind of data security do you think we need to have right now? And is that there, and is that a worrying factor?
So thank you for posting the question. And if you talk about what is there as of now, so I would say not as such any laws which are imbibed to any of the organizations that they should have the data according to some of the policies. But yes, every organization is these days trying to secure the data, because data as it's a new oil for everyone. So from security point of thing, yes, surely first thing which every company is trying to do is as per their compliances. So maybe it is NABL or CAP or HIPAA. So as per the compliances, yes, data protection layer, that is the first thing that we have to comply with, and we have to store the data according to that. The softwares which are also coming these days, they are coming up with the compliances which are like which are compliant to the policies that have been marked by these policy makers, and we are encrypting the data according to that, so that in case if there's a chance that data gets leaked off, like it's been, ransomware has been very common these days. I'll not name the organizations, but yes, somehow it's been the case. And so to protect your data, these are some of the things that surely we have to, as first steps, we have to take care of. Yes, as per as data protection law also, that is also again not an enforced thing. If it comes like that, surely this will help the technology team also to get it implemented in the organization, because when there's a law, yes, that is followed. So that is what we believe as technology specialists. And going forward, how we protect our data in our organization is through different solutions that we have implemented related to cybersecurity and the data protection layer that we have formed for our different solutions, for our servers. And again, if some of the data is, what important data is, how it has to be placed, is it to be placed in-house, it has to be placed on the cloud, how the data is being accessed by the users. Based on that, there are different vulnerability assessment protection layers also which are being taken care. So how regularly you go through that, so none of your data is leaked. That are some of the steps that we usually follow for storing and privacy of the data.
Right.
That's it.
Okay, so since we are we're running short of time, and I want to quickly get in as much as we can on as much data as we can on this data panel. I wanted to quickly go to Dr. Arjun and ask him about, you have so much of data being generated in your labs. Now, just to take off from where we're talking about at ICMR, there's potential for using this kind of data for different research studies. How do you go about that?
Okay, so Roshun, very important when you also asked me the previous question that how can this data be utilized? Obviously, for an individual's healthcare forecasting, treatment, diagnosis, all that is on one side. But looking at the larger benefit to the nation as such. So I would like to mention here various serosurveillance studies also that we've participated in, and also where we work for eradicating tuberculosis, a very small step, but in tier 3, tier 4 cities, in rural areas, etc., where we work along with the government to do testing for tuberculosis. And then based on the data collected, the family members are also given an anti-TB therapy. I think starting from that point, where labs play a very crucial role in collecting that data and then giving it to bodies such as ICMR, Department of Biotechnology, and so on and so forth. I think it's very important, even when it comes to eradicating diseases, also when it comes to prevention and on the vaccination side as well. Also these surveillance studies that are done throughout the country, like even in COVID, we saw that with the increasing herd immunity and the increasing antibody response that we found in the people, obviously the government can also target policies, even the immunization schedule, etc., where suppose there is a particular disease that already has a significant herd immunity, then obviously it's not given that much priority on the immunization side as well. So I think all in all, apart from an individual's perspective and healthcare journey, it's also the larger picture of the nation's health that data can really help to leverage.
Okay. The other question I had, is that these days we have so much of self-diagnosis kits available, whether it's from just taking your blood glucose readings or your BP to various tests that are available right now, and mobile phone apps, and all this data is being collected at the individual level. There's a lot of data available here. But on the other hand, patients interpret this data very differently, and I'm sure even hospitals and labs, you all interpret it in a different form for every patient. Are you seeing that there's a possibility that this is leading to kind of hypochondriac issues, self-diagnosis, self-medication? Is that something that you're seeing happening?
So Roshun, I'll give you a very small example of a very common blood test that a lot of ladies get. It's a hormonal test. It's called a prolactin test. Now what happens with the prolactin hormone is that it's secreted maximum when you wake up. So a lot of females, when they get their hormonal profiles, etc., they want to get a prolactin test done. Now the entire state of mind with blood testing in the country is that all these tests need to be fasting. So usually people go after a 10 to 12 hour fast and get the test done. Prolactin in a lot of cases when you wake up is falsely elevated because it's a pulsatile hormone that's secreted maximum when you wake up. So a lot of times we get this thing that, oh my God, I did my female hormone profile and my prolactin is high. And then if you Google high prolactin, first thing that comes is brain tumor. That's a pituitary adenoma. So I've dealt with dozens of cases with very anxious mothers calling and saying, my God, you've diagnosed my daughter with a brain tumor, when it's a simple hormonal test that you just need to tell them that, ma'am, please don't test it in the morning, do it in the afternoon, and then you'll get a normal value. So yes, even in the pandemic, we saw that before it was called a pandemic, it was called an infodemic. And that was because of the huge amount of information that was circulating not only on media, but also on social media, etc. And I think it's always best to consult a medical professional or your doctor for reliable sources of information. Now, also your point about wearables, sensors, mobile apps, etc. All of these are extremely useful for a daily monitoring purpose. But when it comes to making a diagnosis that guides management, then trust no one but your doctor to interpret these properly and then advise you accordingly.
Right. If I come to you, Praveen, so all this data that is being generated, and a lot of it can also be automated now. What is the role that AI and ML, which he also just touched upon, plays in these kind of data and diagnosis?
Sure. So definitely, AI, as we all know, is making fast advancements, and healthcare is not an exception. And we do see the application of AI in a lot of healthcare applications also. But again, AI, just like any other tool, is something that we should use with proper caution. For example, you were mentioning about the data. If you partner with, say, one institute, and based on that data, you develop your AI algorithms, that algorithm will be very biased towards that data alone. And again, with the diversity that we have, it may not be applicable to some other population. So if you use the same tool and try to apply it against some other data, it might give you false alarms or misdiagnosis. So both are very much possible. So AI is great. We should embrace it, but with a pinch of caution, and we should allow experts to analyze, experts to conclude based on some of the AI tools that we have. And the other part that I want to mention here is, there are a lot of this clinical decision supports also applications that are there in the system, and that you need not have a very high tech tool to interpret. Some of it is very, very obvious, and if you have good systems, a lot of alerts can do a very good job even as a clinical decision support. So with that said, AI is a definite plus, and we see more and more adoption of it, but we should be more cautious.
Okay, and if I was to just come to you, Pooja, about telemedicine is also being used a lot these days, and at the rural level, you have a technician who is probably just checking up somebody and then interlinking with a doctor in an urban center. When we talk about data security again here, what is the the safety that's there at this level, and is that data secure that's coming out of there, or could that data at the local level be misused? What kind of safety do you have in place for that?
So again, it depends upon the solution that's been implemented. So first thing is, yes, post-pandemic telemedicine solution has started being used more as compared to what initially it was. So now it is being used through the softwares which are already being developed, and when we are evaluating such kind of softwares, or any of the organization who's collaborating with the different vendors to evaluate it, that we have to perform the telemedicine, which could be in any of the remote areas. So in that case, surely the first thing comes is, with the vendor that you are evaluating, you have to check the data protection layer, or how your data is being secured and how your data is being stored on their server. Because what is happening in today's days, there are a lot of clouds which are available, and again on the cloud, it's like responsibility which is being clearly mentioned, that it's again the responsibility of the customer to take care of the data.
Their own data.
It's not only the cloud responsibility to go forward, and they will be protecting your
Right.
data. So that is one of the mandates that we need to always remember, and just not leave everything on the cloud. So that is one thing that we need to evaluate with the vendor with whom we would be collaborating for the telemedicine solutions.
Right.
And again, I'll just add to one AI point also, which was mentioned by Praveen. Like at one of the sessions with one of the senior people who have been working on the AI, I attended. So what is happening is, most of the data which is being evaluated or which is being stored for AI, it's not based on India data, because on India right now we don't have that data which is being stored. So it's the analysis is more towards US and UK data. So if we say blindly that we'll follow the same trend in India, that would not work for us, because it's still some years to go forward wherein India cases would add into it and the final solution can be formed for India.
Right. And I think not many people also, when dealing with data, read the fine print. There's always a consent form and an agreement. Nobody reads the fine print. We have just about 4 or 5 minutes left. I'm going to take a couple of audience questions. So if you have questions, put up your hand and get a mic.
Actually, I just wanted to know one thing. Like Dr. Harpreet said that national gold standard parameters, like they are being actually ICMR, Niti Aayog and NSG, they are working on it, like National Cancer Grid, I am saying. My question to you is, sir, why there is so much of overlapping? Why don't we have, like, some time back, like, I have the background of, I have been working with Ministry of Health on RMNCH for almost like 7-8 years, and prior to that in Health Department, NACO, HIV/AIDS. My question to you is, sir, isn't it overlapping of the work? Wherein, like, simultaneously we are having the NHSRC, they feel that they are the resource center and they have to look into the guidelines. Then we have ICMR. Then we have Ministry of Health coming out with guidelines. Then we have the Niti Aayog. And following that, why don't we have something like this, like the way we have for medical devices like 13485 or FDA or something like that? Why are we making it so much complicated? Like for policies also, like ICMR is coming out with stroke guidelines, then Ministry has recently come out with stroke guidelines. It becomes very difficult for the people at the ground root level who are working, because now I am no more working in the government, I am working in a private domain department, in a consultancy company, wherein we have to gather the evidence to talk to the people, talk to the corporates and across world about के evidence क्या कहता है. Evidence के लिए मुझे GBD data है, फिर मुझे HIMS data है, then RCH portal is there, RMNCH tool is there, and it is so much frustrating कि मैं किसको quote करूँ and कौन सा correct होगा. So why don't we have overarching something that will be sort of like tick mark? And I don't know, I think you are there, sir, to speak from the government front, so you have to answer my question.
I'm not talking from the government side, ma'am, but you are absolutely right. There should be unified data systems, uniform data systems. I completely on board with you. But the challenge is, ma'am, the federated architecture which you are talking, where data is flowing from all these different institutions to one particular location, worldwide there are examples it has not been successful. What the answer is, what I just talked about, is system to system communication. We should have a distributed architecture where different organizations, institutions, they should be allowed. Now I'm coming only from the data collection point. I'll come to the policy aspect which you have touched in a moment. Data, different organizations, let different organizations collect data, but there should be standardization in terms of what data is being collected. That is what I was mentioning. There should be a minimum set of core parameters which each organization should collect, must, in addition to others, whatever they require. But those minimum set of core parameters should be able to, these different systems should be able to communicate with each other. So this is one part of, we should not have a very strong federated architecture. This is what my understanding and my feeling after working in this area for last 20 years. Federated architectures have not worked out very well. We need distributed. Now coming to your policy aspect, definitely ma'am, we should have a unified policy, national policy, but then there are certain issues which requires local interventions. There are certain areas which require local, modifications to the guidelines. It is not that one solution can fit to all the problems. Nationwide, there are some issues, we can have national policies, but then there are some issues which we need local policies also. So again, coming to the same point that one solution doesn't fit everywhere, we do require both national, unified, as well as local, depending on the issue.
Dr. Harpreet,
yes,
this
please.
Is Abhishek Bhatt. Hello.
Yes, please.
Hi, Dr. Harpreet, this is Abhishek Bhatt. Manorama is my colleague. While she spoke more on the policy side, okay. I think I'll be more able to connect on the tech part of it. we are already seeing a tech revolution in the form of chat GPT, AI, so many things happening. But there hasn't been any comprehensive policy regarding adoption of those technologies. There are a lot of gray areas. So how do you foresee, in absence of policy and such fast moving technology world, how does it impact health downstream?
Very good question. In fact, it is impacting. We definitely need policies and very quick development of those policies, because the area is developing very fast. This chat GPT, which you just mentioned, it is actually mind-boggling, the information that this chat GPT gives. So I completely on board with you. The ICMR is not the kind of agency which can go and put on this kind of policies. MITI is the, I think, more appropriate agency, and they should work on it, and I am sure they are working on it, because last April, I think they have come up with another policy on data sharing, where there is a provision for establishing a body which will look after the data sharing from different agencies. So again, the federated architecture is not there, it is a distributed, but the agency is federated.
One last question. Yes,
Hello.
Then I think we'll take the rest offline because we're running out of time, but one last question from me.
Good evening to the panelists. My question is to no panelists in particular, but again, I guess Dr. Harpreet Singh, since you brought up the point, you said that Oncquest Laboratories would have its own data information systems, Dr. Dang's labs would have its own data information systems. They need to communicate with each other. The ABDM has interoperable standards such as FHIR or OpenEHR, whatever you prefer, for such communication to take place. The FHIR NRCES resource standards are already present online. They're available. They just need API connectivity with it. So why isn't this happening between not only the organizations that are on the panel right now? Why do you see that there's this that this integration is not happening, is not taking place at the pace that it's supposed to? And I might be wrong, but if you could answer that, and anyone else on the panel also. No,
you are absolutely right. You are absolutely right. I'm sorry I'm taking this, but you can take. The problem is that I am also looking at somebody who can implement these FHIR standards. You mentioned about FHIR standards in some of the data systems. As I mentioned that I am developing data systems for big programs of ICMR as well as ministry, some of the programs. Finding the trained manpower who can implement these FHIR standards is very challenging, very difficult. This is one aspect. Second is the platform. Do you want to build your own platform? Again, we'll come up with the same problem. So there are two solutions to that, what you are just mentioning. One is developing some trained manpower in terms of short-term courses, long-term courses. So education has to be strengthened there. Second is developing that framework where this ABDM has developed this FHIR ABDM standards. So if we can have this as a platform where any researcher can go on that platform and develop FHIR compliance data systems, that will be really wonderful. So we'll see. It will happen. Let's see, wait for another 6 months, sometime. It will happen.
I would like to, can I just add one more point? So you talked about interoperability standards. So standards are there, but if you look at the FHIR itself, it only gives you what the semantics is, but then the usage is dependent on the individual implementation agencies. So just because there is a standard doesn't necessarily mean that those two systems will talk. That is one point. Secondly, there is this concept of MPI, Master Patient Index. Since you mentioned about this single identifier, we don't have a single identifier, and until that point is implemented, we have to rely on MPI, Master Patient Index. So where two records of two individuals have to be given some kind of weightage to see whether they are possibly the same person or not. So there are a lot of other challenges when it comes to implementation, but I'm sure government and other agencies are doing their part to make it possible.
Okay, I think we're out of time and we can take the rest of the questions offline after this. So I would like to thank all the 4 panelists over here. I think it's a very engaging discussion and it can go on forever because data, there's so much to talk about. There's so much of data on it. And on that note, I thank you all for joining me today from this panel.